A warm good afternoon, good morning. Thanks for giving me the opportunity to talk about the Universal Epidemic Outbreak Questionnaire. I would like to talk about a Universal Epidemic Outbreak Questionnaire that we worked on about a year or two ago, and we had it published in 2020. It was about an assessment questionnaire that would help healthcare professionals if they are getting an unusual cluster of particular type of disease, either a new one or a typical one, that they can use to identify the source for the epidemic. And I worked on this project with one of my supervisor, Dr. Parul Sood, and we were able to publish it in the environmental research in the journal. So the outline for the presentation is, I first wanted to go through the types of epidemic because we wanted to know what is the framework for understanding epidemics, the types, the modes of transmission, what are some of the reasons that we are seeing increased number of epidemics, and the significance, why do we need to identify the epidemic source, and what are some of the barriers to epidemic source identification. Then I wanted to briefly discuss about the Universal Epidemic Outbreak Questionnaire. How was it formulated? It was some part of the questionnaire was adapted from the Food and Waterborne Disease Outbreak Investigation Questionnaire. Then I would discuss some of the components of the new questionnaire. What are its advantages over the previous questionnaire? Then some limitations, and briefly discuss about the online database that could be used for knowledge sharing in a patient HIPAA compliant way to facilitate early statistical testing for the disease outbreak. And then I would briefly talk also about the scope for improvement, how this questionnaire could be improved further that would facilitate healthcare workers in helping identify epidemics. So first, I wanted to talk about the different types of epidemics. Like we all know that epidemics are happening all the time. They are most of the time isolated, which is usually called endemic, where the transmission remains in the community and the number doesn't increase to a point where it burdens the healthcare system. We all know that many diseases like malaria, West Nile disease, dengue, they are endemic in many regions of the world, and they cause disease at a community level, and many patients are treated for it. And that's usually the spread though is low enough that it doesn't affect all the people and it doesn't present a threat to the environment. Then secondly, we talk about epidemic, where there is a sudden increase in cases where a large population of a country may be affected, but it usually still is isolated to a smaller geographical area. Like some of the times we have seen epidemics of chikungunya. We have also seen some of epidemics related to Japanese encephalitis that do cause a lot more increase in the number of patients than what usually is seen in that community. And that may happen variably over the time period. It depends upon the temperature, the humidity, the facilitating factors for the viruses. Then finally, we have pandemic, where we have the disease that spreads to all the continents, and it causes a severe threat to the environment and also the capacity of the healthcare system. So first, I want to talk about a little bit about how are germs transmitted. Like most of us know that there are various forms where diseases could be transmitted. It could be in the form of droplets, airborne disease, direct contact, and indirect contact, waterborne disease, foodborne diseases, and vector-borne diseases. So they are transmitted in different ways. And one of the major ways how we try to decrease the disease transmission is by decreasing the germ transmission. So we try to intervene in different aspects. Like if something is spread by droplets, we ask patients to cover their cough. If it is airborne, we try to isolate them and use respirators. If it is more direct contact, frequent hand washing is recommended. In the same way, for each of the germ transmission routes, there are certain interventions we try to do more often to prevent the diseases in spreading faster. Then what are the factors that actually also affect in somebody to get a disease? Because somebody can get exposed, but what makes them too prone to get diseases? And it also differs in different factors. Example is susceptible host. So if somebody is elderly, somebody, children, immunocompromised, they are more prone to be susceptible to certain diseases. So that affects how the disease could be transmitted faster. Then we look at the portal of entry. As we know that diseases that are spread by droplets or airborne are a lot more rapid to spread than as compared to diseases that are spread by more direct contact. So that makes an importance. And finally, we also see at the factors of what systems are affected. Does direct or indirect contacts also make a difference in the disease transmission? Then how all this had happened over the time is that we are trying to understand the interaction of different factors in a community that would make us more understand actually why epidemics are happening so often and what could we do to make it better. So that what this framework comes from is like an ecological interaction. Like somebody told, like if you cut trees, it's not just like you are taking away the factors that change the oxygen and we get a more warmer temperature, but when we cut trees, it's the whole ecology gets affected. There are some organisms in the tree, there are some animals that depend on those trees. And so if you just take away one thing from the ecological system, the whole system is affected. And in a lot of places, the whole ecological system may collapse. And that it leads to more worse outcome that we would usually accept by just deforestation. So when we look at any environmental interaction, the three things that we usually try to evaluate is the host, which is the people who are affected. Then the agent, that is the microorganism or chemicals or whatever is there in the system that could cause diseases in the human beings. And finally, the environment that plays an interaction in this epidemiological triad. So what are the major factors that we are seeing that the interactions are changing? The first one is urbanization. Urbanization and deforestation in a lot of ways usually go together. That is, when we are trying to create urbanization in many areas, it leads to deforestation. So a lot of organisms and how they interacted with each other changes, and that could lead to more diseases. A lot of this is seen like in tick-borne disease. In dengue, we have seen a lot more expansion of the areas that are affected by dengue. And then the virus itself, more and more with the interaction of human beings with the areas that were earlier more under forest cover, and because of warming with the temperature changes, and also because newer viruses are being discovered. So we are having this interaction where we have new virus that were not before, and we also have viruses that didn't cause diseases are now able to cause disease. And we are also seeing viruses that were earlier isolated to certain geographical areas are expanding. So that interaction is happening. We are also seeing changes in the vector behaviors in the same pattern because of changes in the forest area. Then we have more biological components and chemical components. Like there is almost 84,000 chemicals that are present in the world, and many more number of chemicals are continuously being added to our environment. And there is only less than 13% of these chemicals that have been actually tested for acute toxicity. So according to the labeling instructions that comes with the any chemical, only less than 13% have a labeling that is appropriately tested for acute toxicity. And a lot more less are actually having been tested for chronic exposures, either in a subacute form or in the dose that is recommended form. There is very few data that how these chemicals would affect the human body system. So why do we need to identify the epidemic source? So in this picture, we see John Snow, one of the he's also called the father of epidemiology, one of the early epidemiologists who struggled to prove that the water from a particular pump in London was the cause for the cholera outbreak in that town. And he almost, it took him a year because at that time there wasn't the germ theory. It was considered that melasma, which is the air pollution in the air that caused diseases. And from his epidemiological methods, he thought that the water pump was the cause for the disease. But it took him a long time to prove that and eventually be able to stop that pump, which led to the cholera outbreak to getting better. Till now, it still is a struggle for a lot of epidemiologists to pinpoint the cause for any epidemic, especially epidemics that are more subacute. So like we see that a lot of epidemics, when they are caused acutely, they are easier to be detected and be able to be controlled. We saw that with the MERS-CoV, we saw that with some of the newer viruses like Nipah virus. When the acuity is, it's a very acute presentation, it's easier to identify. But we have also seen many epidemics that were actually subacute. And some of the examples of that is the Minamata disease. And we saw some of the diseases that were caused by industrial exposure, including mesothelioma, where the exposure had to be subacute for extended period of time, that it was not easy to identify the source and being able to prove it to make policy changes, because in a lot of cases, the cause has to be strongly established for policy changes. And then for chronic, like musculoskeletal diseases and where we need to intervene in the form of ergonomics, it is a way more less than the acute or subacute form. So epidemiology helps us to detect the epidemiology related factors. So what it really means is that you can only say what are the related factors and what are the risk factors. And just because you're making it as a risk factor and not the causal factors, that is the scope for improvement becomes less. But if there is a risk factor, you can mitigate it. You can intervene at the risk factor level and decrease the disease. We all know in microbiology, we talk about Koch's postulate, where we use the 4 criteria to decide if organism is causing the disease. But we also know its limitation, that not all the microorganisms have proven to fulfill the Koch's postulate. Some of them being Plasmodium falciparum, herpes simplex virus, they don't fulfill Koch's postulate, but we know they cause the disease. So what are all these factors have in the effect on the disease burden? But then eventually when we have the epidemic source identification, it helps us to predict the epidemic curve. We can predict how the diseases would happen. It also helps us to understand the reproductive number, that how many people may be affected if one person is affected, and then how to respond to this epidemic and eventually prevent its transmission. Now I would like to discuss about some of the barriers to epidemic source identification. So one of the major problem is that healthcare professionals lack timing and training. They don't give enough time and training to be able to understand what could cause the epidemic. One of the examples being the wide variety of epidemics in a wide variety of geographical area, like jaundice in India to diphtheria outbreak in Kazakhstan, freshwater puffer poisoning in Bangladesh. When you see these isolated outbreaks, it's really hard for you to actually understand what could have caused this epidemic, or is it actually an epidemic that is ongoing. So that's why in order to overcome this, we need to have more toolkits for the healthcare professional that may help them. Second is the acuity of the presentation that I spoke about earlier. Then, as also I spoke in the interaction, there is a wide variety of organisms continually being added to the environment and to the chemicals that are being added and their wide variety of clinical features. And the limitations of correlation. We can only correlate from the risk factor that these may be the likelihood causes for this epidemic, but taking the causality takes a lot of time. We are overcoming this by a lot of genomics and genome-related studies, and we have a lot more scientific technologies that is helping us overcome this barrier to establishing causality. But still, in a lot of cases, it is still is not a very easy thing. Then finally comes the reporting delay, because whenever there is an epidemic, we are trying to see that how is it being reported. And one of the main thing is initially in the medical field, people are not sure, is this actually the case of what was before? There is no clear case definition. Where unless there is a clear-cut case definition, someone cannot easily tell if this is the case that fits the epidemic or not. Second is administrative. When we do see a cluster, the clinical things and other things take a lot more importance, and then there is not enough time, personnel, and so people are not able to report it in a proper way, in a timely way. And third is socioeconomic. What is the effect it would have on tourism and trade? So that's with all these things in mind, it was important that we felt that it would be a good to have a toolkit that would help the healthcare professional, that they can give to the patient immediately if they think this could be an unusual presentation of too many cases in a short period of time. And something they don't have to spend much time with the patient can fill it up. And then it could be done immediately when the patient could recall things a lot more easier as compared to, let's say it a month later that somebody thinks this is unusual case presentation and somebody wants to go back and ask the patient about the questions. They may not remember the things. We know that it leads to bias. And sometimes maybe a week or two later, the epidemiologists are involved in this outbreak investigation, and they don't have enough information to formulate a good question, epidemiological question and investigation. So having a toolkit that could be given early on would be more beneficial. So there was actually a questionnaire. It's called Food and Waterborne Disease Outbreak Investigation Questionnaire Tool. This is according to European Center for Disease Prevention and Control. They use it for any investigations related to food and waterborne diseases. And a lot of our questions was adapted from their thing, and they have the repository. We adapted it with a proper attribution. So what are the components of this water and foodborne disease questionnaire? So it includes demographic questions to know about the patient identifiers. It asks them disease-related questions, what symptoms they had, then travel-related questions because travelers' diarrhea is a common cause, food habit, allergies, diet, where do they shop, which restaurants do they go to, what kind of vegetable and fruit products they buy, what are the other kind of food products like nuts, seeds, superfoods, meat products, fish and shellfish, milk, dairy, and egg products that they buy. And then finally, it also evaluates if there is any problems with the food products for young children, water and water-based beverages, contact with animals, food dairy, and some closing questions. So these are the components of the water and foodborne disease questionnaire. So we made some changes to it, and the components of the universal epidemic questionnaire includes mostly demographics. It also includes some demographical questions. Then it asks some questions related to their work and work exposures and what's disease-related symptoms they had. Our questionnaire also has a component for patient history, so that it could help us in future that if some patients are more prone for susceptible for the infection, then it has a component about contact history, who are their contacts, then food habits, shopping, then water and animal contact, any additional information, contact tracing, and disease exposure risk assessment. So these are the components of the Universal Epidemic Outbreak Questionnaire. So this is just some of the thing that we have in that. It just tells how their work thing is, how much they were sick, if they were admitted, what symptoms they had, what testing they had done, what have they been diagnosed with, what are their susceptibility factors, are they hospitalized, or they are from a long-term care facility. So it asks them a little bit more about their susceptibility factors. So hence, these are the components of the questionnaire. And what is the other advantages of this questionnaire is it takes work exposure into consideration, because a lot of chemicals are usually related to work exposure, and they are a lot more difficult to detect if somebody is having a subacute chronic chemical exposure. It also asks about contact exposure history, which is important because contact tracing can help disease mitigation. Contact exposure could also help us identify the modes of transmission, because depending upon the contact, it tells us about reproductive number and disease transmission. Then we can also see if somebody is more susceptible, what are their susceptibility factors, so that the prevention could be focused more towards the susceptible host. Then contact tracing and disease exposure risk assessment. So these are some of the components of the Universal Epidemic Outbreak Questionnaire. The major benefit is that this one is more likely to pick up not just the enteral and the foodborne disease. It can also pick up diseases related to chronic or acute dermal exposure, airborne exposures, and vector-borne exposures. And further, some of the other advantages are that it could also, in severe cases, you can try to do the contact tracing. It also has an option where patients could be allowed to take a sample of them and could be tested later on if they would be willing to give some sample for sample banking. And then it has an online database that is in the form of Google form currently, and it could be used for immediately entering data either simultaneously or in a later on date if somebody feels that they have enough number of atypical cases that they want to run the database for some statistics or for knowledge sharing. The database, though, is de-identified, so it doesn't collect any patient-related information. So again, all this would help us to decide about a susceptible host, portal of entry, modes of transmission, reservoir, who could be the people who are reservoirs for this disease, port of exit, and then a portal of exit and pathogens that could be the likelihood. Some of the major limitations is that the food and waterborne questionnaire by the CDC, European CDC, it has a good guidance or toolkit to help the healthcare professionals in filling the form. It gives them full information that if they have questions, this is how it should be addressed, what are the ways they can help the patient to remember things better. Our questionnaire doesn't have currently a guidance or a toolkit, and we have to rely strongly upon how the patient would understand the question as it is. Then our questionnaire is also a lot more elaborate and detailed than the previous questionnaire, which could lead to interviewer or patient fatigue. It is set at a fifth grade reading level for the patient, so that most patient would be able to answer it on their own. But it could also lead to patient fatigue, because that depending upon the time, it usually may take them 10 to 20 minutes, and it may take them longer if they have to really think about it. If it is after some time, that could lead to fatigue, and you may not get all the answers. So any detailed long survey questions or questionnaires usually could cause to the fatigue. And of course, the recall bias is always there for any retrospective study design, where patients who had the disease may tend to recall things better than as compared to patients who didn't have the disease. Our online database currently is in Google form, but there are many established databases that have been there for some of the disease outbreaks. I think NOAC in the US has a database It is not a Google Forms is a little bit of a crude form of a database, but it is good in the form that it auto-populates the Excel system so that statistical test, completing statistical test is easier in case if one wants to perform. The reliability and the validity of the questionnaire still needs to be established, that how reliable and valid it is, that it could be used for on a longer term basis. And then, of course, the time constraints, it does take 10 to 20 minutes to fill up the questionnaire. And it is though set in a way that the patients by themselves should be able to complete it without too much of spending time in it. But still, it still is a constraint of the questionnaire. Then finally is the Health Insurance Portability and Accountability Act, where sharing patient information is always is a little bit tricky, that what is allowed and what is not allowed. Though the online database doesn't collect any patient-related information other than their age and gender. And even that may be a problem in some cases, and some hospital and organizations to be able to share patient-related data. So those are some of the limitations of this questionnaire. So what are the scopes for improvement? We do understand that the scientific knowledge and regulatory systems are lacking in information about exposures, because by the time once somebody sees an exposure, tries to find the cause, is able to establish the cause, and then able to medicate the cause, it may take some years before we would be able to make any policy related changes to improve its outcome. And trying to make it shorter is a challenge, and that is something we need to work on. Second is that the barriers need a multidisciplinary approach, which means close coordination of healthcare professionals, epidemiologists, and multiple people like regulatory authorities. It needs a multidisciplinary approach, which makes it more difficult. It also needs high amount of expertise. In a lot of cases, epidemiologists are not involved early on. Then there are cost issues and time constraints. Then we do need to have adapt a technological and methodological improvement. A lot of surveillance systems are in place for viruses that are established by CDC and WHO, who continually monitor a lot of virus activity around the world. But there is a scope for technological and methodological improvement. And then building good inbuilt surveillance systems so that there is a system within that helps us to identify the epidemic sources. Like in insurances, multiple insurances can have an inbuilt surveillance system when they are getting a particular diagnosis more often, that they are able to maintain that surveillance to see that what could be causing it. And then early epidemiological evaluation as much as possible. And then finally, the Universal Epidemic Outbreak Questionnaire may act as an adjunct tool for early epidemic source identification for mitigating its effect on public health. So those are my references. Thanks, and any questions?